Hi everyone, this is Haley. I'm a fourth year NASA medical student, and this is a poster presentation on the research study Mismatch Repair Assay Use, Characteristics and Outcomes in Early Colorectal Cancer Patients with MMR Deficiency and MMR Proficiency. I have no affiliations or financial support to disclose. Colorectal cancer is a major global health burden, ranking third in incidence and second in mortality worldwide. There have been therapeutic advancements in colorectal cancer which have increased the survival of affected patients, including both conventional chemotherapy and emerging targeted therapies. Targeted therapies are increasingly used in subsets of colorectal cancer patients with tumors that possess appropriate genomic alterations. The MMR system is one of the main DNA repair mechanisms that cells utilize to repair DNA damage and reverse mutations, preventing them from becoming established. MMR testing has been introduced routinely in clinical oncology with the availability of treatments with immune checkpoint inhibitors. Tumors with MMR deficiency have an increased number of mutated proteins that can be presented as neoantigens and serve as targets for the immune system. As a result, MMR deficiency has become a biomarker of response to immune checkpoint inhibitors across cancer types, and testing is required to discover patients who may benefit from treatment with immunotherapy. This study examines the uptake of MMR testing in patients with stage 1 to 3 colorectal cancer over several years at a single cancer center, comparing clinical characteristics between MMR deficient and MMR proficient groups to inform the use of targeted therapies. With regards to methods, the colorectal cancer patient database of our cancer program from 2016 to 2024 was retrospectively reviewed. Data on patient demographics, hematologic and biochemical evaluations, cancer treatment received, and survival outcomes were extracted. MMR status was evaluated via immunohistochemistry for the four proteins MSH2, MSH6, PMS2, and MLH1, with deficiency defined by a loss of nuclear staining. Statistical analyses assessed correlations, and the study was approved by the Institutional Ethics Board. Our study results are as follows. MMR testing was performed in 131 of 264 patients with stage 1 to 3 colorectal cancer. Uptake significantly increased over time, with the greatest increase observed after 2021 being a time when immune checkpoint inhibitor drugs were approved for use in metastatic colorectal cancer. Right-sided tumors were more likely to be tested than left-sided or rectal cancer. There was no significant difference in age, gender, stage, grade, or baseline labs between tested and untested groups. Patients with MMR testing had better survival, although likely influenced by shorter follow-up of the more recent groups. MMR deficiency was found in 30 of 131 tested patients. MMR deficiency was strongly associated with right-sided tumors, grade 3 tumors, and thrombocytosis. Again, no differences in age, gender, tumor stage, or survival were found between the deficient and proficient groups. The most common MMR defect was a loss of MLH1 and PMS2. 19 patients had additional gene panel testing, including KRAS and BRAF. 12 were MMR deficient and 7 were MMR proficient, and BRAF mutations were seen most commonly. In terms of treatment patterns, neoadjuvant chemotherapy was more common in the MMR proficient group, likely due to tumor location. More rectal cancers were seen in the proficient cases. Adjuvant chemotherapy and chemotherapy type, either combination with FOLFOX or XELOX versus monotherapy with capecitabine, was not significantly different between the two groups. Overall survival was very good in both groups at a mean of 21.8-month follow-up. Only 6 deaths were observed, so formal survival analysis was not performed due to low event rate. Overall, in this study, we confirmed the increasing rate of uptake of MMR testing in colorectal cancer patients with localized disease. MMR deficient cancers were more often right-sided, high-grade, and presented with thrombocytosis, which could be a marker of immune activation. Our study presents with some limitations, including its retrospective and non-randomized design, giving risk of bias, the fact that the subgroup of patients with MMR assay performed was smaller, limiting data analysis, and the fact that the study included patients from only one cancer center, limiting generalizability. In conclusion, we observed an increasing use of MMR assay in our study population, with the use becoming more consistent in more recently diagnosed patients. The universal use of MMR testing and the determination of MMR status for all patients diagnosed with colorectal cancer will advance their care and improve outcomes by enabling integration of the most appropriate therapies into their treatment plan. Thank you.